nice interesting برضه presentations اللي قدموها كلها. Thank you once more يعني. وبشكر بروفيسور إيمان طبعا على تنظيمها النهارده للسيشن وتنظيمها للنيورو راديولوجي في القسم عندنا، في الحقيقة عاملة مجهود كبير جدا بشكرها عليها. وطبعا before everything I ask I have to thank Professor Dr. محمد أبو الهدى، هو الليجند بتاع الإديوكيشن الحقيقة في القسم بتاعنا على مدار ال 15 سنة اللي فاتوا، وهو اللي أسس موضوع مؤتمرات، هو اللي أسس موضوع السب سبيشاليتي اللي كلكم دلوقتي متوزعين فيها، ودي فخر برضو الاسم بتاعنا ان عندنا سب سبيشاليتي وعندنا ناس متميزه. والمثل هنشوفه قريب لما توجان تقدم، لان توجان برضو من الامثله الكويسه جدا في موضوع السب سبيشاليتي. فالنكست برزنتيشن هتبقى للدكتوره ياسمين نبيل، بتتكلم عن spontaneous intracranial hypotension, atypical radiological appearance, imaging, mimickers, and clinical look alikes. تفضل.
Okay, today we will discuss spontaneous intracranial hypotension, atypical radiologic appearances, imaging, mimickers, and clinical look alikes. Spontaneous intracranial hypotension is a condition characterized by low CSF volume secondary to leakage through a dural defect with no identifiable cause. Patients classically present with orthostatic headaches, but this symptom is not specific, and initial misdiagnosis is so common. So, understanding the clinical and imaging feature of spontaneous intracranial hypotension and its mimickers will lead to more accurate diagnosis. Here we discuss conditions that mimic the radiologic and the clinical presentations of SIH. SIH is estimated to affect 5 per 100,000 people per year, with predominance for women. The most important predisposing factor are the mechanical stressors exacerbate the underlying weakness in the spinal dura, like connective tissue diseases, speculated osteophytes, herniated discs, and nerve root diverticula. The most characteristic features of SIH on intracranial MRI imaging include diffuse backmeningeal enhancement and the brain sagging. The common presenting clinical symptom are orthostatic daily headache, which is the main, cranial nerve palsy, gait disturbance, and cognitive dysfunction. Here are some MRI images that show to us the main presenting feature on MRI, which is the diffuse backmeningeal enhancement of the dura on the axial T2 and T1 post-contrast image. Also the brain sagging as shown here compared to the normal brain on sagittal T2 MRI image. Also, it can be presented on MRI by bilateral subdural fluid collection or hematoma. Also, an MRI can be presented by diffuse pituitary gland enlargement, engorgement, and enhancement. The condition with some shared imaging features include Chiari type 1 malformations, subdural fluid collection, conditions with dural thickening. As we see here, it is a patient with Chiari type 1 malformation. We should differentiate it from a patient with SIH. Sagittal T1 demonstrate Chiari type 1 malformation with descent of the cerebellar tonsils about 1.4 centimeter below the foramen magnum level. The prepontine stern here is preserved, not effaced, and the pons maintain its rounded ventral morphology. But in P, which is a patient of SIH, sagittal T1 shows severe brain sagging due to mild descent of the cerebellar tonsils at the foramen magnum level. The pons here is effaced and lost its rounded contour, and the prepontine stern is markedly effaced. Another condition to differentiate between bilateral subdural hematoma and the initial presentation with SIH. Sagittal T1 shows subtle decrease in the mamellopontine distance. Otherwise, the typical stigmata of SIH are not present. The coronal post-contrast T1 demonstrate large bilateral subdural hematomas, as we see, with mass effect on the cerebral hemisphere. Hyperdynamic CT myelogram, not shown here, showed a leak in the thoracic spine, and targeted blood patch was performed. The subdural hematoma required evacuation due to the cerebral compression, and all the patient symptoms resolved and the hematoma didn't recur. Another differential is the IgG4-related pachymeningitis. Here is a coronal contrast T1 image for a 53-year-old male patient with IgG4-related disease, show abnormal pachymeningeal enhancement. Follow-up study after steroid treatment demonstrate interval near resolution of the pachymeningeal enhancement. And this is a table to show the main distinguishing feature between the common radiologic mimickers and the SIH, which is type 1 Chiari malformation, as we mentioned in the previous slides, the subdural fluid collection and the condition with dural thickening. The most important distinguishing feature in Chiari type 1 malformation and SIH is the midbrain descent. It is absent in Chiari type 1 malformation but present in SIH. Subdural fluid collection due to any other cause like trauma or any other condition, usually unilateral, but SIH patient usually bilateral with accompanied by brain sagging and dural enhancement. The condition with dural thickening like IgG4 related diseases like neuropsychirrhosis and tuberculosis showed focal or diffuse pachymeningeal or sometimes accompanied by also leptomeningeal enhancement at the skull base level with the other systemic symptoms of these diseases. But in SIH, the pachymeningeal enhancement diffuse, non-nodular. Okay, common clinical mimics to SIH include also postural orthostatic tachycardia syndrome, orthostatic headaches, cervicogenic headaches, and vestibular migraine. The first clinical mimicker is the postural orthostatic tachycardia syndrome. How to differentiate? It is the most common non-leak cause of headache that is triggered or worsened with upright posture. The measurement of the sitting and standing heart rate and blood pressure is a reasonable screen for this diagnosis, as the patient of postural orthostatic tachycardia syndrome demonstrate rapid increase in the heart rate and relatively stable blood pressure on standing. The second is orthostatic hypotension that caused by autonomic failure or the medication effect or severe hypovolemia, but not spinal CSF leak. Another common cause of orthostatic headache, whereas spinal CSF leak associated headache is typically centered in the head and focused in the occipital region. The cervicogenic headache or vestibular migraine, worsening headache when attaining an upright position, which raises the suspicion of a spinal CSF leak, result from a disorder or a lesion of the pony-cervical canal or soft tissue of the neck, and this is usually accompanied by neck pain. Most commonly, the offending pathology is osteoarthritis of the upper cervical spine. In conclusion, cervicogenic headaches are usually unilateral and accompanied by neck pain worsened during neck movement. The most important, they are relieved by pharmaceutical blockade. And this is a table shows the main distinguishing feature between the common clinical mimics and the SIH. Conditions that occasionally coexist with spontaneous intracranial hypotension include, first of all, cerebral venous sinus thrombosis. The patient may his first presentation by this clinical pathology due to compensatory venous engorgement and stasis, secondary to decrease in the intracranial CSF volume. Also, the presentation may be due to frontotemporal lobe dementia. Due to diffuse brain sagging, there is obstruction of the venous flow and swelling of the diencephalon may precipitate to behavioral and personality changes. The patient can be clinically also presented by pituitary gland apoplexy due to compensatory enlargement and congestion of the hypophyseal veins. Also postural orthostatic tachycardia syndrome, as we discussed previously, and superficial siderosis due to microhemorrhage as a site of the dural defect or the traction at the skull base. We will discuss this in our cases. This is a case, SIH presenting with venous sinus thrombosis. 43-year-old man presented with sudden onset headaches. Contrast enhanced C1 image demonstrate diffuse, smooth, non-specific, thin pachymeningeal enhancement. The patient presented to the emergency after 3 days later with marked increase in his headache and sudden onset of right lower limb extremity weakness. The unenhanced coronal head CT demonstrate high attenuation and expansile content within the superior sagittal sinus and the cortical veins, compatible with acute dural venous sinus and cortical vein thrombosis. The sagittal, MAP, and the coronal image from a contrast-enhanced CT venogram confirm long segment acute expansile thrombus as a filling defect within the superior sagittal sinus, as well as multiple bilateral superior cortical veins. While he was being treated for sinus thrombosis, he reported that the headache were orthostatic in nature. His condition deteriorated with progression of the thrombosis despite the treatment. The parenchymal hemorrhage, axial and sagittal T2 MRI image, as we see here, demonstrate ventral extradural fluid collection. Hyperdynamic CT myelogram, not shown here, was performed and a leak was found at the speculated osteophyte T1-2 level. SIH also may be presenting, as we discussed, as a pituitary apoplexy. Here, sagittal T1 image and the coronal post-contrast T1 demonstrate hyperintense lesion filling the cella. The patient was diagnosed with pituitary apoplexy of macroadenoma. However, the MR imaging actually demonstrates the expected intracranial stigmata of spontaneous intracranial hypotension, including severe brain sagging and dural enhancement. Despite extensive evaluation, the source of the leak was not found. The patient was treated with non-targeted blood patch. His headaches and imaging findings resolved. And the last, the patient may be presented also by superficial siderosis, as we discussed, due to microhemorrhage at the site of the dural defect. Here, a 37-year-old man was presented with episodes of dizziness and loss of consciousness, was found to have diffuse posterior fossa predominant superficial siderosis. On axial SWI image, subsequent imaging of the spine demonstrate a ventral extradural fluid collection. A subsequent hyperdynamic CT myelogram identified the source of the CSF leak, which was surgically repaired. So, in conclusion, spontaneous intracranial hypotension is caused by various types of defects in the spinal dura and subsequent CSF extravasation. Patients classically present with orthostatic headache, low or normal CSF opening pressure on lumbar puncture and the brain sag with diffuse pachymeningeal enhancement on MRI imaging. Many radiologic and clinical findings may mimic these classic findings, and conversely, secondary changes from SIH can give rise to symptoms that imitate other conditions. Because SIH is a curable condition, it's important for physicians to recognize its non-classic presentations and to be familiar with the differential diagnosis of its radiologic and clinical findings. Thank you.